good evening, and good evening. This is yours truly, Dr. Luvuyo Payeni, your host for Dr. V Talks. And yes, welcome to yet another exciting episode of Dr. V Talks. And this week we are continuing, as you know, that we have given you some insight into saying we are acknowledging and appreciating that July is a mental health care month, and as well as making note that it is indeed a Mandela Day. I would come up front and have a disclaimer. I had planned to participate in a Mandela Day from church. Unfortunately, I had other commitments. I had to rush to Boxing South Africa activities. So I can confess that I had not done any Mandela Day activity for 2026. So please don't feel bad. Don't feel ashamed if you have not. We do acknowledge that indeed a number of South Africans, even across the country and across the globe, did participate in Nelson Mandela Day yesterday. But anyway, they always say that is for the month. So I still have a chance to come back and say, this is what I have done. Or I can invite you to come and join Dr. B Talks on a Mandela Day activity of 67 minutes. So you must just give me some ideas and share how you would want us to be doing that. So yes, that is how we are acknowledging our July month. And thank you very much for all of you who continue to join and support Dr. B Talks, as well as to our partners when it comes to the simulcast broadcasting from Sowetan, as we are live on Sowetan live as we speak. So yes, thank you very much. And we started the month, and we did, as you know, that we try and link our topics to follow from each other and to try and give us a sense and capacitate us into a global space in terms of issues that relate to yet this month mental health issues. But also, let's also remind you that we do have opportunities and moments where we say, you know what, we do have a guest, but that guest must come back. We have listened to her, we have been accepting and being graced by her in terms of the previous episode. And I listened, the team of cars always lashes at me when I say, why do you promise on air that you're going to bring people? But we said, the viewers have got the final say. And if you had asked us to bring someone back, we do that. So our guest for today is no stranger to Dr. B Talks. Actually, I was saying earlier on when we started off air to say, you know, the one thing wonderful about the episode today and that she's coming back is that it also expresses how we are growing as a platform. When we had her in one of our topics earlier on in the year, we had not partnered with Sowetan Live, so we were not having this stream yards and simulcast broadcasting at the time. But also, she was one of those that we were failed, or technology just decided to show us flames on the day, and we ended up having to use a virtual communication as we could not connect in terms of having her on the screen. So yes, we listened, we ended up having a great conversation with her, but you never had a chance to see who she was, and you never got a chance to see her in person at the time. So when we were looking at the topics for today, we're like, no, she must come back. She must come back. She must also come and see how we have grown, but also she must see how we appreciate her input, that even now, when we have a topic that is relevant to her space, we would also consider that she must be the one to deliver the topic for us. So that is why we are here today. I'm going to be presenting and asking her to continue where I would leave out certain things deliberately. Our guest for today is a pediatrician by trade and practice, who is based in Chris Hani district, all the way from Epondweni, Empuma Kapa, in the Eastern Cape. And she has been here on the show before. She had presented to us a topic before, but we said, let's bring her back. We would like her to give us some more insight on the topic of the day. She's also doing a lot of work when it comes to issues that relate to severe malnutrition, newborn management, HIV and TB management, childhood epilepsies, cerebral palsy, developmental delays. So we said, please come and empower us, come and support us, come and share and educate like you did the last time, but you can trust as a topic for the day, look at autism. But importantly, we know that kids are going back to school on Tuesday. So what can we learn? What can we be empowered on? What can we look out for in terms of supporting and ensuring that our kids don't also fall prey to mental health issues because of things we don't understand about them, because of things we miss about them. So that's how we had picked up this topic to say, let's make it part of the month. However, trying to get close to attending and responding to issues that affect the kids. I'm introducing to you none other than Njobeni, a doctor and a friend and a supporter of Dr. B Talks, and all the way from Krisani Ekomani in the Eastern Cape. Dr. Njobeni, please, I left out a couple of things deliberately because I would like you to also, as you are joining in to the viewers, to just share a bit and introduce on things that I left out. I know you've given me what to say, but I deliberately left out other things because I want you to introduce yourself to the team and to the family of Dr. B Talks. Over to you and welcome. And thank you once more for being available to be part of Dr. B Talks.
Thank you so much. Thank you so much, Doc. I think wagqibile intro ibambile ikho yobandi ngubani. I just want to express Doc nje uba as part of ke mhlambi bio yam that I am someone who after specializing in those big cities and big hospitals, I just felt drawn, honestly, to going back, to our rural Eastern Cape, and I just so happened to land in the very district that I also originate from, because I am from Ekrisani district, pa kwela cala laseNgcobo, kwaMhlabi yaLingana. So I came back to serve my community, and specifically abantwana baseKrisani, as I was once umntana waseKrisani. So I am very passionate about rural health, and really do believe in Doba, any South African child born here within these borders should have equitable access to healthcare. Yeah, them being born in some rural area or in an urban area, their access to healthcare should not be determined by where they are from, but rather just because by virtue of being a South African, they should have the same benefits. So that is, yes.
No, I think that I like the fact that, because which becomes an important issue, or maybe an element about how you are in terms of even your practice, your trade, but also your passion and calling, to say that over and above everything else that we've learned at school and what we practice, I am passionate about making sure that we expand access and services, most especially to our rural communities. And I think that's one thing that is very significant, and we must applaud you for that. Because sometimes people think that when we specialize, or when they specialist services, it's meant for the urban, it's meant for the cities, it's meant for the developed. And you are trying to raise that point to say, when we do go to school and study, we want to help every child in the case of pediatricians. So it's not necessarily supposed to be secluded or peculiar for only those that have got other areas where they live. So thank you for raising that. And also, I think for us, it's a lesson and also a take-home message already to say, those that are finding themselves maybe being in a less urbanized or a less sophisticated or a less developed area, they must not think that they do not deserve to have some form of specialist care, especially in this case when it comes to pediatrics, so pediatrician care. So thank you very much for that. And yes, I left all those things out for you to be able to bring and say to us and share with us that there is this passion that you have when it comes to rural health. Thank you very much for that. Without wasting time, our viewers nowadays are telling us that please, let's have enough time with our guests, as we encourage them as well to start dropping in on some comments and also preparing their contributes and experiences that they would like to share with us on the box, so that we can read them during the show. As I was saying, July month, we do know that it's a month for mental health awareness and mental health, trying to encourage people to be aware of issues that relate to mental health. But also, I felt that when it comes to looking at the issues that relate to pediatrics, Most often than not, we do have those kids that get to be indirectly exposed to mental health issues only because of a particular diagnosis that they have. And also, the parents thereof end up now having a mental health burden because of having to care for a child with a particular diagnosis. Moreover, when it becomes so obvious and clear that there is an element of misunderstanding, okay, we are having a gap there by we don't necessarily understand what the child has as a diagnosis, but what the child may be going through. So that is why we said, all right, amongst other diagnoses that we know are out there that create these mental health risks, if I may use that, for both the child as well as the mother, is autism. And that's why I said, in you understanding and being passionate about childhood development as well, how about you take us through the issue and the diagnosis and the condition of autism? How can we improve on living with children with autism? How can we support parents who are living with children with autism? That is where we are today, and that is where you're going to take us through and empower us and educate us. But importantly for us as a family is for us to be able to take something home to make a life better tomorrow and support those that need our support. What is autism?
Thank you, Doc. Uh, I think okokuqala, when we're defining it, we look at the features that we will see. It's a clinical diagnosis that we make for umntana that is on the autism spectrum. So we look at DSM-5, which you will be very familiar with, Doc. So it defines the autism as persistent deficits that the child will present with in social communication, in interaction, alongside repetitive or restrictive behavioral patterns. So these symptoms will usually appear in early childhood, but there are instances where the diagnosis of a person being on the autism spectrum is made later on, even in adulthood. But
Okay.
mostly they will be severe enough in early childhood for it to be identified. Usually the diagnosis by the age of 3 can be made, but we know in our communities that it also depends on how astute the parents are in noticing and how quickly they seek help when they notice something abnormal, because mostly it's got to do with checking that the child is developing normally. But in most cases in our communities, you will find an instance where there is already a red flag by 18 months, but unfortunately, even the clinic sister at the PHC gives an instruction of, no, let's wait and see. Who else in the family maybe had delayed speech development? Who else maybe had this abnormality, this or that or the other? So instead of quickly referring for intervention or for a thorough assessment, people usually take the wait and see approach, and so most diagnoses then happen later on, between 3 to 4 years, 4 to 5 years, which is already a bit late if we want to have a good outcome with the interventions that are available to us. So there are certain criteria again that we will be looking at to say, when you do have this, then the diagnosis of being on the autism spectrum can be confirmed. First of all, we have criteria A, where we look at the social and emotional reciprocity. Now, as children grow, even from the time that they are on the mother's lap, they are taking up social cues from the mother. During the breastfeeding time, they are taking up social cues. They are learning empathy, they are connecting, eye contact, and all those things. But you will find that with children on the spectrum, that give and take, of those social cues doesn't occur. okay? And the older child, you will see what we call gaze avoidance. So instead of when you call them, they will turn, but will look elsewhere rather than looking into your eyes. So that is what we mean by them not having these social and emotional cues functioning normally. Then,
Khaya bamba
even when you look,
Gqithi. Ndithanda le part ithi, actual fact, we must all be cognizant that as early as when the child is trying to have their first breastfeeding or first interaction with the mother, this is where this development we expect it to take place. So let's be mindful that that is when the child is already starting to develop when it comes to social interaction. I'm liking that, because I want to raise it in the Nati, let's be mindful in the when the child is now being breastfed, yonke le noise and chaos that is around siyamphazamisa umntwana in terms of learning some of the cues from the mother, in terms of the eye contact. So I think I wanted that to be noted so that we know, but the environment in which that we are some of the behaviors that we are then going to be expecting them to do later on. So I just liked how you expressed it to say, as early as that time when they are busy having that moment of breastfeeding, when they are trying to respond to the mother, when they are trying to react, that's when all these things are starting to happen, and we must be mindful of that. Thank you very much. I hope I did not distract you a bit. Thanks.
no, not at all, Doc. I like that you picked that up, especially in this day and age with our millennial mothers, with our Gen Z mothers. You know, time and time again now, we are still fighting the battle of breastfeeding because unfortunately, with formula feeding, the same doesn't really occur because most people, they take into a bottle and give the child, and then the baby, everyone is happy that a 4-month-old is able to handle their bottle, and then they lie there on the side and the mother is busy with something else. But now a more troubling thing that I'm observing is that even the mother now that is breastfeeding, most times that time for this interaction that we're talking about is not quality time. It's not set apart. The mother is on TikTok, the mother is on Facebook. So we are missing, we are missing, we are creating a gap now in us actually establishing from early on, normal development in a baby. And so even with nonverbal communication, then they will also have issues with reading that. And you'll find that even their communication is very limited. And then even when they do understand, they can receive an instruction, but their interpretation of what they are hearing may be very literal. So then they end up struggling to initiate and maintain relationships, friendships. And you will find the mother, telling you even on the day that they present that this child, even a crash, is a loner, is likes to isolate themselves. If there are other siblings in the household, is not really playing with them, is not interacting with the other children. So that is what falls under criteria A. And then we have the criteria B, which is the restrictive or repetitive behaviors. You find a child who is busy, just wants to spend all day, every day, either spinning around or flapping their hands or skipping, jumping up and down, or they might be jumping up and down on furniture. So all of those, even when they are playing, you'll find that their play is not, imaginative play, that rather they will take a toy, maybe Lego cubes, and instead of putting them together to make a structure or a person, but rather just line them up in a line, and they can spend hours just fixating on this play that they are involved in. So even their speech, you will find the speech is repetitive. Sometimes they have what we call echolalia, and that is also one of the things that usually causes a delay for parents to move, because they will say, no, but this child is able to pick up something that is being said on the TV. But when you really listen now to the quality of what is being said, no, actually this child is not initiating. They are not speaking what is coming from them, but rather whatever they are hearing, they are just echoing it and repeating it. So the mother gets comforted into say, oh, but the child is able to speak, but only what is being uttered, on TV or on radio. And so that is one feature of it. And then there are always, they appreciate sameness. Their routine should remain the same. If anything falls out of that routine, then it destabilizes them, and you may get them having meltdowns or having temper tantrums. So this is what we will usually see. And then we also have criteria C, criteria D, and E, looking at the developmental aspects. That, first of all, the onset should be in childhood, and then should also come with impairments, that affects their functioning in various areas in their life, as well as knowing that whatever these features that you are seeing are not better explained by another differential diagnosis. It cannot be better explained by the child having maybe intellectual disability, or having cerebral palsy, or having some other developmental delay, maybe it's an X-prem or so forth. But also it doesn't make it easy that these conditions can be co-occurring with autism. So you can get a child with autism and having intellectual disability, but being on the autism spectrum is not synonymous with having intellectual disability.
Okay. So I think that's the I like the emphasis of reminding that we could be on the spectrum, but it does not mean we are therefore having these other conditions. Yes, but also let's be mindful that they may also exist as well as comorbidity, and there would be that interaction in terms of the presentation and whatever. I'm listening to you explaining, and you even said earlier on, from 3 months we should be able to pick up some of these concerns that you have mentioned. Now I'm trying to find out how can we respond to a mother who is listening, or a potential mother who is planning to fall pregnant, and also a mother who is now ticking the list of your examples and symptoms. But the question that remains is there anything that has been said to say, I could have done something better when I was pregnant, or I could have picked it up when I was pregnant? I want us to assure or to reassure the mothers in terms of how have we come to say what could have or what should have, or they should also not necessarily be inward and blame themselves in terms of the pregnancy profiling. I'm sharing this here because, of course, we do note that you would have a very perfect antenatal care, a perfect antenatal response, even from the mother and the couple for that matter. And everything would have been done as and how obstetricians would have expected it to go. But I just wanted you to be able to just reassure, or just to share with them how they should then approach and be able to not necessarily want to fall into a risk of blaming themselves and their pregnancy thereof.
Well, thank you, Doc. That is very crucial, because the blaming game usually comes up, especially with a couple. So I just want to indicate that for the vast majority of cases of autism spectrum disorder, there is no causal link to anything that we can point to and say this is what causes autism. There are still studies that are ongoing. There are some suggestions that it might not be a single cause, but rather a multifactorial causation. But I think for those instances where there is an identifiable teratogen, like exposure to valproic acid, we know that if valproic acid first of all, we should not have any adolescent or woman of childbearing age on the valproic acid because of the known teratogens. The most notable one that people are scared of is the neural tube defect, but actually it has also been associated with various neurodevelopmental disorders, and autism being one of them. So in that instance, I think that is the only thing maybe we can look at, and look at prevention strategies. And then, second of all, high risk scenarios where we might think, okay, the child might be affected, is in an instance where there is a history of a sibling or a parent being on the spectrum themselves, which makes sense because there is a genetic aspect. There is a genetic link on some cases. And then there are also some disorders, like Rett syndrome, like Fragile X, where also they might be associated with autism spectrum disorder. But as far as going into prevention or looking at what one could have done, in pregnancy, I think the only thing we can look at is exposure to teratogens that we know to be associated with neurodevelopmental disorders.
All right. No, thank you very much. And I think that's what we want to send as a message out there, that as long as you do attend, you plan first your pregnancy and your family. But secondly, as long as you attend to your antenatal care as prescribed by your obstetrician, by your primary health care practitioner, as long as you also are interested in the growth of your pregnancy and your child in utero, and you'll be having clarity on how far your pregnancy is going. So if all that goes well and there has not been issues that were raised, please don't blame yourself. Don't think that maybe you could have attended antenatal somewhere else, or maybe don't think because on that day you missed, you went the following day, or you went a week later. As long as during your antenatal care, we keep on updating you that all is well and everything, please don't blame. There has not been any linkage or any causative things except for those of the exposure that which your antenatal care practitioner would have expressed if there was any exposure for you. So as long as your pregnancy would have went well, there was nothing untoward, please don't start feeling as if you might have done something better before your baby was born. I just wanted us to start there because remember, when you talk of someone having to pick up things as early as 3 months, someone might start thinking that maybe I was the fault when I was pregnant. I should have done it. So I wanted us to be able to assure and maybe comfort and console those mothers and those fathers that please, it had nothing to do with how or what you could have done differently when it comes to your pregnancy and your antenatal care. Thank you very much, Gregor, for highlighting that. As we come back to our viewers, please feel free to drop your messages. Please share your experiences. Some of you might know of a sibling that is already diagnosed of autism. Some of you might be parenting some of the children that are autistic. Some of you might be through your profession, whether as a teacher or an occupational therapist or as a healthcare worker, dealing with children that are autistic or in the autism spectrum. Please share your experience. Please help us empower others. Please pose some of the questions that you think might benefit our viewers. And we're looking forward to all of us being able to empower each other on the Dr. B Talks. Masibuyele kuwe ke Gqirha Omkhulu, as you were continuing, you've given us a clarity in terms of the different spectrums and in terms of the different presentations thereof, and you were continuing just before I stepped in, so you may continue.
Thank you, Doc. Then when you have established that now you are dealing with a child with who is autistic or has got autism spectrum disorder, then you also need now to to define the severity of the disorder, because not all of them are the same. I like what one of our rehab team members said, that if you have met one child living with autism, that is exactly what you have just done. You have met one. So you don't meet one and think you know all of them. They are as different as, as our fingerprints. So we have who have level one. Level one, it just delineates the amount of support that they would require. So level
Okay.
one needs some support. Level two, they require substantial support. And level
Mm.
three, they require,
Extensive.
even more substantial support. So then, even as you are starting now to structure a management plan for this child, that level one or level three you are not going to handle them the same. And schooling, when you're looking at school going age, chances are level one might cope in a mainstream school, but level three definitely
Okay.
would need
Okay.
to be in an environment that caters specifically for children with this condition or with special
Mhm.
needs. So that is why we need to classify according to this severity. So usually our literature would indicate that there is this difference between the sexes, between female, the prevalence in females and males, putting that there is 1 to 3 or even up to 1:6 proportion females to males, with males being more affected. But lately there has
Okay.
been more evidence that what we are seeing is actually that females, especially that I would be level one, are very good at masking their symptoms.
Oh, okay.
Yes, it's more socially acceptable maybe for boys to be rambunctious and running around, kicking, jumping, and doing all that. Whereas for a female from an early age, everyone is like, no, sit here, sit pretty, play with
Mm.
dolls, do this, do that. So for those ones who are high functioning, they learn early on to mask the symptoms so that they align with the social norms. So you find
Mm.
most of females getting their diagnosis later on in life, because the other features, though they may be masked, when they are needed, when they go to a work environment and they need now to work in an environment where they are, they are not used to the system, then they fail to function, they fail to rise up to
Okay.
the occasion, only to find that, oh no, this person is struggling now with this routine. And when you go backwards, oh, there's also this, and then it goes back to childhood.
Um,
It was missed. So there might not be such a huge difference between the two sexes. Now, the important bit is, as I alluded to earlier on, that
mm.
instead of taking a wait and see approach, our PHCs, even in the community, our ward-based PHC outreach teams, everyone, we are now supposed to capacitate them. There are
Okay.
screening tools that are
Mm.
available. Fortunately, I think you would know Dr. Sikriti.
Yes.
She made, she researched this part and came up with these tools that they are being used in, in the first world countries, just as a tool, so that at certain stages before the second birthday, a child is assessed and screened. So
Mm.
these
Mm.
ones are not that intensive. It usually takes about 15 minutes to 20 minutes to do, just so that anyone that we pick up that is got it deficits, let's say in the domain of social and communication skills in that assessment tool, then we red flag that one for further assessment in a district hospital or another level of care, so that we do not have children getting late diagnosis. Also, I know that in the last 2 weeks in our province, the integrated school health services,
Oh, yes.
they
Oh,
had a
yes.
workshop, yes, and autism was part of the conversation that was being held there, whereby now these tools will also be part of those baseline assessments they do in certain grades. I know that one is done in grade one, then also in grade 8, if I'm not mistaken. But at different intervals in the school, in the child's school going years, they will get screened for autism, and that is where we hope to catch, those ones that may have been masking, or maybe the parents were not, were not careful, in observing their children's development, and so did not pick up any abnormalities. And also, we know that our children are coming from different backgrounds. Some parents, or some are being raised by grandparents. So
Yes.
there are access to platforms like this, where someone might hear on radio or on TV that there is this issue. Ukraine might not know that. And all yena yenzayo is, when she sees this behavior abnormal, she takes iswazi, abanishe.
Yabetha yena.
Yes. So we need to keep those people in mind. So if we are going out into the community, visiting households in the schools, then at least every child will have at least a screening done, and then whatever we pick up as a deficit gets referred timeously. Yes, Doc.
I think I want to go back to the part where you were saying we have got these three different categories, if I may use that, especially when it comes to what support or what approach is expected in terms of supporting these children. And you did make mention that for the first category, they can even survive or be compatible. Maybe let me use that word, compatible with the mainstream education system. For me, I feel that's one thing that we also need to remind parents of, to say, please don't shut out when you are told we are suspecting that the child is on the is on the spectrum, because it can also happen that this child may probably be falling under category 1. But you would find that sometimes our parents and families, once they hear the word, they just already would probably think of what or how or who they might have seen, who may fall in category 3 for that matter. And like you said, even our rehabilitation team would remind us that it's not a one size fits all. Don't say because you've seen one, you've seen them all. So I think that's one message that I wanted us to emphasize and remind our viewers on, to say, please be mindful and be patient with your medical team and your healthcare workers, even when they are taking you through screening and identifying some of the symptoms or some of the behaviors that you might pick up from your child. Don't just shut out and think that now I've heard my child has got autism. Please, I'll listen to you next month again. Or I can't accept this. Let's allow that everything must sink in, but also ask questions so that you can be empowered and understand exactly where your child may form in the spectrum. Maybe that's another thing that we need to be reminding, that there is a reason why there is a terminology of spectrum and you keep on referring to a spectrum. It's because we are saying that the child might be in between or might fall at various expressions or at various degrees of how affected they are. So let's be mindful as parents, let's be mindful as family, and as well as healthcare workers, when we also deliver the message, let's be mindful that this is a spectrum. And as we go along, as we assess, as we support the child, we may then be able to say it is either category 1, category 2, or category 3. I thought let me emphasize that part, because I feel it's important, especially on what we want to achieve here at Dr. B Talks, which is to empower people and make sure that tomorrow someone else may go and say, you know what, actually Makulu and actually Dan, I know that you guys had said umntana autism and saphuma up. Now there is new information I would like to share. This is what I've heard yesterday. Can we still be patient and give it a chance? So thank you very much for that, and trying to remind us that the support that might be needed may as well also be different as we go along. I like the other part that you mentioned now at the end, to say we should, as well as healthcare workers and these platforms, also try to make sure that we spread the message as wide as we can, but also simplify it for those that might also not be at our same level. And those of us who've got an opportunity, whether we participate in outreach, whether we participate in radio slots, whether we participate in church talks, let's please make sure that we use those opportunities so that the person who's caring for that child who might not be here on the platform now will still get the same information or get to be empowered in the same way that we are. Thank you very much for that, a bit. As I'm trying to check if from the team, do we have any comments or messages that we have, and you may put them up for us when you see them at from your side. Thank you. Thanks.
Thank you, Doc. So it's very crucial, Doc, le education siyenzayo. Also on a one-on-one basis with parents. I know in clinics, across the country, there used to be a slot whereby as people are waiting in the waiting room before they are served with consulting rooms, there would be general health talks. So these are some of the talks that should be held in our various facilities and institutions, whether it's a hospital or a clinic, because sometimes nyani, it's a lack of information that people are not bringing umntana for assessment. And so the parents as well also need to know there are certain red flags that, even if you are taking a wait and see approach, but these red flags should really prompt one to move. So for instance, if umntana, as we were saying, is avoiding eye contact or does not maintain it, that is something that you need to take care of. If the child, by the time they are 9 months of age, when you call their name, they do not turn, to you. That is also something that we need to look at. And this is also very crucial because sometimes the child who has got the speech delays, which is one of the main features that we will see when we are assessing autism. That is what most parents usually present with. But you find that also has got a hearing impairment. So that is something we need to exclude. But the condition autism on its own, a receiver being able to receive the dog will not be able to turn because they are not having that reciprocity that we talked about earlier on. And also blunt facial expressions, whether they are sad, happy, angry, the face is just, they have a blunt affect. So that is something that should be a red flag. Not being able to engage in interactive play by the time that they are 12 months of age. By the time they are 12 months of age, when you wave goodbye, there's no reciprocal waving bye-bye. They should be able to do that even earlier. But if by 12 months it's not happening, that's definitely a red flag. And they are not able to share toys and play with their peers, between 15 to 18 months of age, that is a red flag. And they're not pointing out, objects of interest, because normally at that time, even if they are not, yet able to talk much, but they point out, things of interest. There's a car coming, they will pull you and point. But in a child that is on the spectrum, that doesn't occur. So by the time they are 2 years of age, if they are not able to pick up or notice when someone else, whether an adult or another child, is sad or hurt, then that might be an issue. We said most they fail to show. So even if there is someone crying, you find that they're just not affected by that. So that is something that is a red flag. And they fail to, we know that earlier on, as toddlers around the age of 2, children do not play in pairs. They will do parallel playing. One is here, the other is here. But around 3 years of age, that's when now they start, playing, collaborating and playing together. But in a child that is on the spectrum, that will not occur. They will continue playing in isolation. They do not do pretend play. one of the best parts of childhood is pretending you are a teacher. The others are your pupils. One is the superhero, the other is the mother, the other is the father. But in children with
Mm,
ASD,
mm.
they do not engage in pretend play. So by the time that they are 5 years of age, you will see, that they are really behind in their social skills. So that is some of the red flags that we pick up. And then those comorbidities that we talked of, we spoke about intellectual disability, but one of the others that also sometimes people call one the other and call the other, autism spectrum is usually confused with ADHD, because some of
Okay.
the features, the behavioral issues, the inattention, the failure to respond, all those things, one person might look at that child and say, oh, I think this one has got ADHD.
Mm,
But
mm.
you need to do the two, assess this one, look at the criteria for ASD and check if they fit, check the one for ADHD and see if they fit. Because again, as we said with intellectual disability, they may coexist in the one child. The one child may have both ASD and ADHD, but some people will call ASD ADHD or call ADHD ASD. So we need to make sure that we do the two separately. And then if you see that there is an overlap, then it's a child who's got a comorbid ADHD. And it's a very high
Wow.
percentage of
I
our
think
ASDs that have got ADHD, up to 70%. So it's not an uncommon
okay.
co-occurrence. Yes. Oh, ndibethe emlonyeni,
Yes.
Doc.
All right. Yes, no, no, no. Thanks, Gqirha. Bendithanda le part yama-red flag. Yabona mos nabo Dr. B ba-red. But yes, the fact that we are saying, even if you might not be particular or so precise in terms of picking up some of these things, but please note that these are the age gaps or milestones. These are the things that should then raise flags for you and make sure that at least you pay attention to those. So I like the fact that you summarize to say, let's look out for these red flags, or let's have a high index of suspicion when it comes to when they get to these certain periods or certain times. I see that we do have an input and a comment from Demi, who is representing. Maybe can we have it up as a team? And then I could go through. Thank you very much. The comment here is saying, I have experienced people's reactions to an autistic child, and it was harsh and frankly sad. A neighbor's child had wandered into my uncle's house during his funeral and was caught and scolded, but I was able to see she was on the spectrum. And when I tried explaining to one, wanted to hear me out, majority of the adults were stuck on she is naughty, labeling them as being naughty. And I could see the child was in major distress as I was sad and upset. I eventually managed to calm her down and took her back to her home. I knew this from a show I had watched called The Good Doctor. There seems to be a lack of understanding in our Black and Brown communities. What more can we do to educate them? People don't want to understand a child is just naughty, or a child is not just naughty. That is the comments that we are having from Demi that has come up. One, appreciating and expressing that indeed this would help and empower people to notice some of these behaviors. But importantly, it's a major concern as to we are still a mile away as a community in terms of accepting, in terms of understanding, but in terms of supporting and creating a community that cares and supports autistic children. You may come in as well and share a bit with some of the issues that you had to deal with.
Yes, no, Doc. Demi's experience is not unique. There are parents, there are grandparents who have had to, bazile going to church, bazile going to malls, because most of these children, they also have sensory input issues.
Okay.
You know, they might be hyperreactive or hyporeactive to any of our senses. So a child who has got hyperreactivity to the auditory stimulus, any place where now, you go into a mall, the first thing you hear is the loud music. It might be pleasant to us, but for that child, it's
Yo.
overload, it's sensory overload, and immediately they
Mm,
will have a meltdown. They start screaming. They will put, fingers in the ear, and it's a whole production. So we need to really this education from the core, the family that has got this child, ensure that when you are going into a space, you think about all the eventualities. It's a big mental load, unfortunately, and we see a lot of depression, with the caregivers and parents of children uh, that are on the spectrum. you know that can be something as simple as buying them noise cancelling ear headphones might make that trip, turn out differently. Because if they do not have that sensory input, then all is well with the world. Or you play
mm, mm,
something that is pleasant to them. If they like a particular group, you know, um, certain type of music, you play that, and so then they are more calm and they are easy to deal with. In churches, you would expect a different outcome, but there's a lot of judgment, there's a lot of myths around, mental, anything that is not understood, and in that space, then it will be spiritualized, and labels put on a child. So it's one that requires us really to go out into the community to educate um, those that are affected and those that are not, because the reaction to this child, is probably coming from people that have never encountered a child, that is probably level 3 on the ASD. And also, just also, something as simple as what we usually see with other conditions, like, those bracelets that
mm,
have a person's medical,
mm,
any condition they have, because these children, most of them are non-speaking. So if they are in an environment where, because they can sometimes wander away from home, it's
mm,
not a
mm,
planned
mm.
outing. They were playing outside in the yard, and then they escape and they are wandering around. So at least if you can see, okay, this child is autistic, then there might be a bit more understanding, rather than being punitive and lashing out.
I'm already identifying that this is probably where we should make an effort as the communities to assist. That let's understand that raising a child on its own may be expecting the parents to go an extra mile. Now, our role where we can support them is not to increase the burden by our reactions and how we treat them. Because now I'm already wondering and concerned about this family, like you say. Prior to pregnancy, they were already enjoying going to church, going to social activities, going to malls. Now they have to, all of a sudden, because of how we treat them, now they have to dissociate and alienate and isolate themselves. And of course, that will not come just as easy as that. It will come at a price. You've even mentioned the extreme one of saying that the parents end up going through depression themselves because here I am. I used to be a bubbly person. I enjoy going out and I enjoy going to church. I enjoy going to these places. Now I can't because of how people treat my child and how people treat us as a family. So I think that's one thing that we should be able to do better as the audience that is listening and watching through Dr. B Talks, and also those that will be empowering with this message going forward to say, let's be sensitive, let's be patient with not only the children themselves, but equally so the parents. But also the one thing that I liked as well was sort of empowering the parents thereof to say, also be able to be mindful and see what also environmental factors are stimulating your child to then be in a extreme behavior kind of, and try and work around those and you made an easy example of, if you know, and I think I've had one parent who told me that there are days and times they prefer to go to the mall, precisely because they are raising an autistic child. And they would tell you that I can't go to the mall when it's busy, when it's chaotic during the day. So if I do not make it before 9 o'clock or 10 o'clock in the mall, I would rather go in the evening, especially knowing that I'm going with my child there. So I think it's also a reminder to the parents that let's be observant and take note of which are these environmental stimulus are affecting the child, so that we can work around them. You also made an example of earphones, when the noise is a stimulant in the main, so that at least we can minimize that. So thank you for those, and I think those are the practical issues that we wanted to come out of the conversation, so that people can say, this is what I'm going to take home, in terms of making it better and supporting those that are living with autism and raising children with autism. You may come in as I'm busy checking if we do have any other comment on the chat box, on from our viewers. Please continue to also show us. I know some of these topics you would rather just listen and take notes. We appreciate that, but please continue to send those hearts, send those thumbs up, and send those emojis, so that at least we know we are still together in the platform, and we still continue to be a Dr. B family. You may continue, Grega.
Yes, and so some of the conditions get documented that usually come about with a child having ASD. We mentioned the ADHD, ne? And also a major one is sleeping disorders. Most of these children struggle with sleeping. They will have insomnia, and again that impacts on the parent, because if a child that is having this disruptive behavior, you cannot sleep peacefully when they are awake. If they are awake, you have to be awake, and then the mother is expected tomorrow at work. So it's a whole issue. So have to find ways, to manage those sleeping disorders, because most of the time, in the next 24 hours, if they haven't slept today, tomorrow is going to be a horrible day. It's going to be a day full of temper tantrums, full of meltdowns. So you manage those. There are certain pharmacological agents that we use that can be, used to manage insomnia. And also, some of them usually also have comorbid seizure disorders or epilepsies, and those also need to be controlled and managed appropriately. And they usually have unusual eating patterns. Some of them will have pica, whereby they eat non-nutritive substances. I think the worst one I've come across was a child that the mom reports that they will have a bowel movement in the nappy, proceed to take it off, and then ingest that. So it's very distressing. And she was indicating as well that from ingesting it, then it would also be taken and the walls are covered. And so she indicated that, things like having friends or family drop by, randomly in her house, it doesn't happen, because she cannot, on any given day, she cannot assure them that they will find an orderly house, with clean sofas, with clean walls. So it can take a toll on the mental health of the parents. And they are usually very picky eaters, abantwana. Sometimes they are put off from certain foods by the texture, sometimes it's the color, sometimes it's whatever. And they will just move through days where they are having a green week and all they will eat is green food. One of my colleagues was indicating was just on a green apple spree, just eating green apples from sunrise till sunset. So you can imagine, guys, that they will also have some deficiencies now, some micronutrient and macronutrient deficiencies. Some will be, stuck on just having carbs every day. It's wheat peaks, it's noodles, it's pap, and not a fruit or veg in sight. So it's very tricky. Those things that we take for granted for these parents and these children, Getting through a meal can be a whole battle, and multiply that by 3 times a day, multiplied by
Eish.
however many years that this child it takes to train them, and get them to a place where they are self-sufficient. For the older children, be on the lookout, if unusual moods, or because they are also liable to have anxiety or depression, especially around puberty and the adolescent stage.
Mm.
So you need to keep that in mind. And if you do find that they do have, then it must be managed appropriately. And then you will see that some of these children, they are little daredevils. They have no concept of fear. They can step in front of a moving vehicle because they have no sense of danger. So they are
Oh.
very likely to be, to get injured. And also sometimes because of frustration on the caregiver's side, they might also be abused. They might also suffer, from non-accidental injuries. So we as healthcare workers, and as the community, we all need to really to support these families so that, yeah, it's a protection as well for the child. Because if we are also frustrating them, then the outlet will be to abuse the child just to let off some steam. So we need to be cognizant of those things. Yeah. So I think even for the children that end up going to school, also keep an eye out, for bullying, because even if they are level one, they still have some deficits in their social interaction, in their
Mm.
communication,
Eish.
you know. So children get as cute and nice as they are and innocent as they are, but when they are mean, they can be very mean. So look out for children getting bullied, that are on the spectrum,
Mm.
as that can also lead to self-harm, for the older ones, especially if they have untreated depression disorder.
Wow. Um, yes, ixesha lutshaba and yeah, I don't know singalibamba phi sithi siyalitsweba nje kancinci lingamane lisileqa kangaka. As you preparing for your parting and words, as time unfortunately it's against us. I think the message and the expression for us should be, or is that of let's be patient with each other, both for the children as well as for the parents that are raising autistic children. But I like also what you also saying and raising that as caregivers as well. Um, and this cuts across whether you are the biological parent or you're just a caregiver. Let's also be mindful and as much as we might get to a point where we're frustrated, but let's also be mindful and that we need to be patient with them and not get to a point where we unawarely or subconsciously take out our frustrations on them. And but the other issue as well is the issue of saying sometimes they do not comprehend and see anything wrong or dangers in some of the actions that they take because they are dissociated to some of these issues. So we must be mindful that it's not deliberately to annoy you when they seem like they want to cross the street when there's a car coming, or they want to get close to that heater that's on and stuff like that. So let's just be mindful of some of these behaviors, that they are not intentional, to annoy or irritate us. But let's look at the bright side as we are concluding our report and closing remarks. I must say that I've seen quite a number of parents that have been sharing their journeys. And we do know and appreciate that social media nowadays plays a vital role, and sometimes may also have a risk of being misinterpreted. But I must say that I have been following some of the parents that have been sharing with us their journey. Sometimes it has come to a point where they are able to empower us, where we see the different um, sides of the coin. One of the expressions would be that they are happy, the child is behaving, the child is adaptive, the child is independent. But the next day, you may also see that the child is actually out of control, the child is having this violent behavior or this non cooperative behavior. So we want to thank those parents. We want their contribution, because it's not only about being on social media, it's not only about just putting it out there, but it's a way of empowering and educating us, those who don't have or are not raising autistic children. So we want to say, as Dr. B talks, that we do appreciate and we do value those efforts to say, this is what I am going through, this is what my child is going through, and this is how I would like to empower someone else out there so that they also know that they are not alone. Because we would get to opportunities where we see that other parents will say, I have been drowning in my corner, and thank you for sharing this. At least I know that I'm not alone. So I just wanted, as I'm going to give you an opportunity for your closing remarks, to say, as Dr. B talks, we are following with sometimes comments on some of their pages, but we want to come out and say we do appreciate your efforts. We understand that all you're trying to do is to empower someone else out there so that they don't have to go through some of the struggles that you went through. Gqibezela Dokotela, we have now gone 5 minutes past our time, and I would like to give this an opportunity to you to have your closing remarks. Thank you.
Oh, thank you so much, Doc. No, just to highlight once more that once the diagnosis of autism spectrum disorder is made, it's not the end of the world, for parents out there, for family members. It's in fact just an opportunity to see, these children are special in their own way. Just how much you can contribute into into unmasking what it is that this child has
Oh,
brought to
yes.
the world, what their gift is, for the world. We need, as well as clinicians, to be mindful of the fact that we cannot manage this alone. We need it's a multidisciplinary team that needs to be involved. And I usually tell the mothers that come to my clinic, but beyond the time when we have made a diagnosis, we've made the assessment, we've done the counseling, and we are all up on board as to what we are dealing with the parents. Beyond that, the most important part of this puzzle of management is with the allied team, our OTs who do a splendid job, our physios, our speech and language therapists, our um, dietitians, to manage all these, the plethora of issues that we talked about. Because all the doctor is done is identify it, refer to SASA maybe for financial assistance in our public sector, refer to the educational psychologist, do this, do that. But the people that are going to make a difference in the functionality of this child, that the parent can see a difference in how independent they end up being, or in how we end up learning how the way, the strategies that we need to implement so that this child can learn. The people that make the most difference are the allied health, the rehab team. So unfortunately, in our setting, these people that are so crucial for this are exactly the people that we do not have freely available in most of our facilities. You find smaller nyana pockets, in regional hospitals, in some bigger district hospitals, but they are not freely available. Because as we were talking about screening earlier, let's say now we end up doing this screening, 100% well. So we end up with all these people flooding the system, awaiting a day, to be seen at the clinic. In the meantime, we could be starting with OT and speech and language therapy, even as they are waiting for the big assessment to be done by Dr. So-and-so at the regional hospital level. So, but those are exactly the people now we need to decentralize and make sure that from clinic A, that is in Krisani, they go to the district hospital to be seen by the OT, by the speech therapist, whilst awaiting for the clinic appointment that is 6 months down the line.
Okay.
So that is the long and short of it, Doc. Thank you so much.
Thank you very much, Doc. Thank you very much. And also, maybe just to also put it back to us as a community, as well as the parents that are raising autistic children, please let's be mindful and take an understanding of the value add of the rehabilitation team. And sometimes it is not so much about us frequenting the pediatrician, but there is also value in us frequenting the rehabilitation team. I know that our communities like to be doctor centric or doctor centered. Umdu will rather honor your appointments and demand when even when you say
Yes.
when I'll see you in 2 months' time, they'll be like, no, doc, can I see you again next week or next
And they will
month?
proudly tell you, no, I missed the OT, I missed the don't, but I came to yours. And I'm like, you can miss mine, but never miss those ones.
Exactly. Yes, so I think that's one thing that we're also encouraging to the parents out there that we work as a multidisciplinary team, and once we have done our assessment and made the diagnosis, there is more value from the rehabilitation team. Maybe it's also a sign and a call to my team that we need to find a topic and host one of our rehabilitation services team, so that at least we can get to expand our knowledge and understanding of their service. Let me take this opportunity. It is now 11 minutes after an hour, and we had booked you for an hour. And we always say at Dr. B Talks, we still want you to come back next week, Sunday. We still want our viewers to be tuned in. So we try by all means not to go beyond the time that we had requested. And we know that sometimes we still want to continue and we still want to empower more. But let me take this opportunity and thank you so much, Dr. Njobeni, for always availing yourself and always being prepared to come and empower us on this platform and to empower our viewers on Dr. B Talks as well as Sowetan Live. So thank you very much for making time. And to our viewers out there, thank you so much for continuing to support Dr. B Talks and our partner, Simulcast Broadcasting Sowetan Live. We thank you so much. And we may continue to invite as many people to join and follow Dr. B Talks both on Facebook as well as YouTube, and follow Sowetan, and continue to share all our topics and make sure that as many people get to be empowered. Those that are able to influence, please try and influence your areas of influence, whether it be at church, whether it be at work. Let's try and expand the knowledge. Let's try and empower as many people as we can so that the messages can go out there. It's not only for us on the platform, but ours is to create this awareness and this platform for people to know better and for us to spread the message. Thank you very much for always tuning in. We're going to meet next week as we conclude the month of July. And I'm not going to tell you our guest. You'll only be guessing for the whole week, and we'll disclose and tell you who's our guest on Friday. So thank you. Continue to always join and tune in whenever we have these sessions, and support us on Dr. B Talks as well as Sowetan. That's it for tonight, and thank you very much for always tuning in. Have a blessed week ahead, and continue to follow us on our platforms. Thank you very much. That's it for tonight. Have a lovely evening.